Welcome. Today we're going to do an evidence-based deep dive into lumbar disc herniation with radiculopathy. This is really tailored for us as practicing orthopedic surgeons, and it's built right from the NASS guidelines and the key literature that helps shape our clinical approach every day.
So, here's our game plan. We're going to walk through 5 key areas. We'll start with the basics, getting the definition right, and then build all the way up to the practical stuff, patient selection, surgical techniques, and of course, outcomes.
Okay, let's jump right in. Before we can talk about treating it, we all need to be on the exact same page about what it is. And for that, the NASS clinical guidelines give us our consensus definition.
And here it is. Now, the most important thing to remember here is that this is a 2-part diagnosis. It's an anatomic finding, the displaced disc material, that absolutely must be paired with the clinical features, the radicular symptoms. You need both. You need the imaging and the classic story. This standard is really going to be the foundation for everything else we discuss.
So now that we have our definition, how does that actually translate into the clinic? Let's focus on the exam findings that the evidence tells us are the most reliable.
The NASS guidelines get pretty specific, and these 5 are the core of it. This is our bread and butter, right? Manual muscle testing, sensory exam, and our provocative tests like the straight leg raise. These are our best tools for linking a patient's symptoms to a specific nerve root, long before we even get that MRI report.
This image just says it all, doesn't it? This is what we're looking for. Radicular pain isn't just back pain that goes down the leg. It's specific. It travels, usually past the knee, and it maps out a very distinct dermatome. Nailing this pattern is absolutely critical for figuring out which nerve root is in trouble.
Okay, let's use a classic clinical example. Say you've got a disc herniation at L3, L4 that's compressing the L4 root. What should you expect to find? Well, you're looking for this pattern. Sensory changes over the anteromedial leg, some potential weakness in the quads, and maybe, just maybe, a diminished posterior tibial reflex, though we all know that one can be tough to get.
All right, so this brings us right to the heart of it all. This is the big question. You've confirmed the diagnosis, now what? What does the evidence actually say about surgery versus non-operative care? This is the core conversation we have with our patients day in and day out. So, the takeaway from the level 3 evidence, like the Thomas et al. Study, is really this clear trade-off. Look, at 2 years, the functional outcomes tend to even out. But, and this is a big but, surgery gives patients faster, more durable, and statistically significant relief from their pain. And for a patient in agony, that speed matters a lot.
So building on that, let's get a little more granular. Let's say a patient is a good surgical candidate. It's not just about whether to operate, it's about how. And just as importantly, we have to be really honest about where the evidence is still thin and doesn't give us a clear answer.
This is the next logical question, isn't it? Once you and the patient decide on surgery, you have to choose a technique. And that choice really ought to be justified by the best data we have available. Well, when it comes to automated percutaneous discectomy, the NASS guidelines are about as blunt as they can be. It gets a grade I for insufficient evidence. What does that mean in practice? It means based on what we know right now, we can't recommend it, but we can't recommend against it either compared to a standard open discectomy. The jury is still out.
And this is so interesting because it shows us why the evidence is weak. You look at the key study here, Haynes et al., and you see it was downgraded for some pretty significant methodological problems. The sample size was too small, there were issues with the patient population, and they even changed the procedure mid-study. It's a fantastic reminder for all of us to be critical consumers of the literature we use to guide our practice.
Okay, let's start to bring this all home by talking about outcomes. We'll quickly summarize what predicts a good result, go over the must-not-miss complications, and pull out the key takeaways for your practice. The literature is pretty clear on this. These 5 factors are our best predictors for a successful surgery. This stuff is so essential for counseling patients, right? It helps us set realistic expectations and, frankly, helps us get better at picking the right patients for the operating room in the first place.
Now, of course, we have to talk about the big red flag, the one thing we can never, ever afford to miss, cauda equina syndrome. You see this constellation of symptoms, bilateral leg weakness, saddle anesthesia, bowel or bladder changes, and it is a true surgical emergency. This requires immediate, aggressive action to prevent permanent damage.
And beyond that absolute emergency, we also have to be upfront with patients about other potential long-term problems.
If treatment is delayed or inadequate, especially when there's severe nerve compression, these are the unfortunate outcomes that can occur: chronic pain, permanent nerve damage, and that really difficult to treat neuropathic pain.
You know, this slide really sums it all up. Taking care of these patients is not a solo sport. From managing their expectations before surgery to helping them recover and dealing with potential complications after, it takes a village. Working closely with our colleagues in pain management, physiatry, and physical therapy is absolutely crucial to getting the best possible outcomes.
And that really brings us to the final thought I want to leave you with. If we accept that the main advantage of surgery is faster pain relief, then the real challenge for us becomes, how do we get better at using all those predictive factors we talked about to identify the exact patients who will benefit most from that specific advantage? Answering that question is how we truly apply these guidelines to make a difference in our daily practice.